Ma'am, please start.
Yeah. Good evening, everybody, and a warm, rather a hot welcome on this 8th day of May. Respected President, Maha IIP Dr. Chejara sir, Secretary General Dr. Amol Pawar sir, Central IIP EB members, Maha IIP office bearers, MMC observer Dr. Sanjay Gosavi, senior pediatrician from Nashik, senior doctors who have joined, and all the participants. I welcome you all to this wonderful session of Pictorial Pediatrics. It's a great idea by our president. It was floated in his Maha IIP President Action Plan, and it's the brainchild of scientific convener Dr. Bhavesh Mithya. So thank you both of you for this wonderful idea, which makes learning and keeping up with pediatrics much easier to the practicing pediatrician. So, and this is really a very famous or a very liked session, as you can see from the experts who have been on this today is the 4th session, and attendees are always above 300, 400. So before we begin, I just want to mention that today is the 8th May. It's a World Thalassemia Day. Nearly 15,000 children are born with thalassemia every year in India. And newborn screening will definitely help. So let's pledge today that we'll diagnose, treat, counsel, and support the patients of thalassemia and their relatives. As pediatricians, I think we are definitely the first point of contact for them, and whatever little we can do or whatever we can do will definitely make a big difference in their lives. So hoping for a better world for thalassemia patients with newer developments and research in this field. Today we have two eminent experts, Dr. Indu Khosla ma'am will be speaking on sleep captured for pediatricians, and Dr. Ravi Ramakant will be speaking on ABC of pediatric chest radiology. So with this small introduction, I request our president, Dr. Chejara, to please give us his welcome address. Over to you, sir, Dr. Chejara.
Sir, kindly unmute. Sir, kindly unmute.
Okay. Thank you, Anuradha madam. And welcome, friends. Good evening, everyone. Welcome to one more episode of Pictorial Pediatrics. You know, the visual impression is the best impression. And the concept of the program is that you learn by visual impression, either by picture or by the videos. And already there are more than 280 delegates. So that shows the success of the program. Today, I welcome Dr. Indu Khosla and Ravi Ramakantan, sir. He would be talking on the chest X-ray, and madam has all beautiful recorded videos of the different pattern of the sleep. And I thank to Indu madam. She agreed on a very short notice when we met for Mumbai IIP program. So, and she said that she has a good collection of sleep patterns. So I thought that better to share with everyone. So welcome Indu madam. Thank you. And over to you, Anuradha madam. We can start the session already. We are late.
Dr. Amol sir will not be speaking.
I think he has not joined because we have another CIP meeting.
Okay.
I have to join that
fine.
also.
Okay, yeah. Fine. So I'll just introduce Dr. Indu Khosla ma'am. She has 30 years of experience in pediatrics and pediatric pulmonology. She's a gold medalist from Mumbai University. in pediatrics in 1989. She has trained in various international centers in the US and UK. She's one of the core faculty members in designing asthma module and respiratory tract infection module for the IAP. She's also a trained bronchoscopist. She has conducted workshops for pediatricians on respiratory tract infections, asthma, sleep medicine, and bronchoscopy. She has deep interest and expertise in the field of sleep medicine and obesity. Today, through her session on the sleep videos, she hopes to sensitize the general pediatricians to the sleep studies. Sleep is an important part of our life because I think it is as important as normal breathing. And sleep study, which is polysomnography, detects sleep disorders. So, through her beautiful and interesting videos, Dr. Khosla will be discussing behavioral insomnia of childhood, obstructive sleep apnea and beyond, obesity and the obesity syndromes, parasomnias, and movement disorders. So basically, I think the take-home message for us pediatricians would be that sleep disorders are for real and when to go for sleep studies. So with this introduction, I think we all of us are geared up for a wonderful session by Dr. Indu Khosla. Over to you, ma'am, Indu Khosla.
Just a second, madam.
Yes.
Ravi sir has joined. So once madam session is over, then we can start with the radio.
Sure.
Okay.
Thank you, Dr. Chajera, for inviting me, and Anuradha for those words of appreciation. I hope to go through my presentation with a lot of quick videos, which I think a practicing pediatrician should always know. And I hope by the end of the session, I would have sensitized you on the importance of sleep. Because of the lack of time and the amount of ground that I would want to cover, it will not be a complete review of a topic, but it would be just sensitization of a topic. But post the session, if any of you have questions, I would be very happy to answer you on your chat, on the chat box. Also, I would appreciate that it's an interactive session. So when I show a video, I would be glad that if you answer in the chat box, and I would respond to your chat messages. Okay. Now, what is healthy sleep? I think it should be a sleep which when you hit the bed, you should fall asleep within 20 minutes. You should stay asleep through the night, and you should rise without being yanked out of your bed with an alarm blazing, without much trouble each morning. And you should not feel drowsy during the day. So if you get onto your car and you doze off while you are going to the place of your work, hopefully when you are not driving, you are probably either underslept or sleep disturbed. So through this pictorial representation of my sleep disorders, I know we all doctors are always sleep deprived. I hope to keep you awake. I just give you a classification of sleep disorders, and this list is ever growing. We have insomnia, and in children we have something called as behavioral insomnia. Yes, children do have insomnia. Then you have a whole lot of sleep-related breathing disorders, right from central apneas to obstructive sleep apneas to sleep-related hypoventilation or sleep-related hypoxemia disorders. Then you have disorders of hypersomnolescence. In children, we don't see so much of narcolepsy or idiopathic hypersomnia. Whatever we see in children, hypersomnolescence is more because of insufficient sleep, which could be of any reason. We do see hypersomnia as a psychiatric disorder, which we are seeing more now in adolescent children. Early onset psychiatric disorders are being picked up, and there is a huge interplay between psychiatric disorders and sleep. Then we have circadian rhythm disorders, which you see in adolescents. You have parasomnias, movements, and you have a list of other sleep miscellaneous disorders. Now, I would ask you many times, what I'm showing you, is it normal? Is it abnormal? And whether normal or not normal, is it actionable? I'm going to show you this little video, and all the videos that I'm showing you, I've not put, I've not listing the eyes because I've taken permission from the patients. Now look at this.
Ishan, it's 10 o'clock. Let's sleep now. I can play for 5 more minutes. Okay, you can play for 5 more minutes. Now let us sleep now. It is 10:30, beta. I want to read a storybook. Okay, come, let's read a storybook quickly. Bring my neck.
So is this normal? Is it abnormal? Is it actionable? You can answer in the chat box.
Come on, let's sleep now. It's
Yes, so I have people answering that this is
10
normal
o'clock.
but actionable. Yes, you're right. Okay, so this is what children do, and this is commonly
Come on,
called as.
Krishan, wake up. It's morning. Good morning. Let me say it for 5 more minutes. Rise and shine. We'll be late for school.
Okay, so I got some answers to say that this is normal, but it is actionable. This is behavioral insomnia of childhood. You have two varieties. You have the limit setting variety and you have the sleep association variety. You also have a third variety, which is a mixed variety. The limit setting is when the parents don't set limit. There is no strict bedtime. There's no good sleep hygiene. Older children may be watching gadgets, etc., before going to sleep. And there's one with sleep associations where the mothers continue to breastfeed the children beyond the age of 1 year, etc., at night, rocking, nursing, swinging, requiring the parent to go to sleep and co-sleeping in an older child could be a sleep association which prevents the child from getting adequate sleep. How do you treat it? You have to establish a good sleep rhythm and a hygiene. Develop a consistent bedtime rhythm. The environment of the bedroom should be optimum for the child to sleep. Put your child to sleep when the child is drowsy but awake. So even if it's a breastfed child, many mothers would breastfeed the child and the child would sleep on the breast. Advise them to put the child to the bed when the child just starts getting drowsy, and you can allow them to go off to sleep on their own. And they, of course, many kids will not go off to sleep. It's easily said than done, and they may just start shouting or crying. There is one way of handling it, that crying it out, or it's called extinction reaction. Let the child cry, leave the child. Automatically after some time the child will tire out and go to sleep. Or you can have a graduated extinction. You can stay for 5 minutes the first day, stay with the child for 10 minutes the second day, and gradually wean yourself off the child. So that's something called as a graduated method or the no crying method. Both of them are fine. I'm going to show you another video, and if you have any guesses, please put it on your on the chat box. Look at this child. So this child came to us, and the mom says, "My child does not sleep. He is all the time awake. He's restless, and he's not sleeping through the night." So what do you think you're seeing in this child? So you're seeing a child who has a very restless sleep. If you watch him, he is continuously scratching. And nowadays we see a lot of children with atopy, eczema, and these are kids who have an altered sleep just because they have a problem. So before labeling a child as behavioral insomnia or a child who does not want to sleep, one must rule out organic disorders. All right. So this is abnormal and definitely actionable. So when you have medical conditions like reflux disease, you may have children with obstructive sleep apnea. You may have rhinitis, asthma, eczema, food allergies, colic. These children also may mimic behavioral insomnia. They may not want to sleep. They may cry out. So please rule out medical conditions before calling it behavioral insomnia. Now look at this 14-year-old. He goes to bed at 12 with his cell phone, falls asleep anytime between 1 to 2 a.m. I'm sorry about the p.m. And it's difficult to wake up in the morning. Weekends, he sleeps late, even later than 12, and he gets up post-noon. But when he gets up post-noon, he is fully refreshed. Is this normal? Is this abnormal? Or is it actionable? Yes, the answer is to some extent it's normal, but it becomes abnormal because children use gadgets at bedtime, and therefore it is actionable. This is something called as delayed sleep phase. So if you look at the third bar here, the children fall to sleep much later than they should, and they get up later, and then it becomes a rhythm for them, and it becomes a problem every day. And therefore this needs to be treated by disciplining them to go out to sleep at a proper time. Adolescents, their circadian rhythm is pushed to a little later, so they get sleepier a little later than younger children. That is understandable, and they do need 7 to 8 hours of sleep. So one has to talk to them about physical activity, not using gadgets before going to bedtime, and this is how you would treat them. Very often you should ask them to maintain a sleep diary. And this way you are involving the child. Ask them to mark when they get into bed, when they fell asleep, if they got up in the night, how long were they awake, and in the morning what time they get. If you get a sleep diary from them for the previous 2 weeks, you will be able to diagnose a delayed sleep phase syndrome. And you will diagnose a delayed sleep phase syndrome if it is happening over the last 3 months. Now I'm going to show you 3 very fascinating videos. This is a doctor's child who came to me from Germany because there they were asked to do a sleep study, and she was not getting an appointment, and she was worried whether this child is having some sleep apnea, whether he's having seizures. Can you see what these children are doing? And any idea what they are? Anybody on the chat box? So in the middle, he was not crying. This is how his behavior was. So these are normal behaviors, especially in REM sleep. You will see abnormal movements. And this, when he gets up and starts crying, could be a confusional arousal in a child, which is like a parasomnia. Now he soothes himself and goes back to sleep. So these are all normal behaviors. We did a sleep study on the insistence of the parents. So we told her that this is a normal phenomena. We did a sleep study and it was normal. Okay, look at the eye movements. You think it's basically a seizure, but no, it was not a seizure. Now look at this neonate. So this is a kid only in sleep got this jerky movements, okay, continuous jerky movements. And when he was awake, he did not have it. He was actually referred to as on anticonvulsants. And when we looked at it, it was just a benign sleep myoclonus. This disappears as the child matures. So you must look at, you must diagnose a benign sleep myoclonus by this kind of movement, which are only in sleep, in otherwise a developmentally normal child. Okay, you wake them up and the movements disappear. Now you look at these 2 kids. Okay, look at this first kid and look at the sound that is making. This is a child he was 1 year, 10 months old, not even 2. Look how he's breathing. Okay, and of course, look at the other child here. And can you see something else in the other child? See, watch him, how he breathes, or the sounds he makes. Watch him, what will happen to him. Almost as though it's an engine which is running, right? And look at him. See, he had a small kind of an apnea. So the first kid had adenoidal hypertrophy, it was a child who was less than 2 years of age. He had a severe sleep apnea on polysomnography. We did a polysomnography because he was a very small child, and to take a decision to remove the adenoids at this age, we thought it was better to do a sleep study, and that showed severe sleep apnea. A medical management had failed, and this child underwent tonsil adenoid removal. Not tonsil, only adenoid removal. The other kid, if you see, is an achondroplasiac. This is also a child who is most predisposed to developing obstructive sleep apnea because of the craniofacial abnormalities they have. He also had adenoidal hypertrophy, and that was compounding his sleep apnea. So when you have children with craniofacial abnormalities, children who have got a snoring sound like this, please do think of obstructive sleep apnea. So as I mentioned, polysomnography was done, ENT reference was done, and tonsil adenoidal removal was done. So when you have a child with a mild OSA, if you have done a polysomnogram and the AHI is less than 5, you can try a medical management with steroids with or without montelukast. But if the AHI is more than 5, then you should look for adenoid and tonsillar hypertrophy, and also look for any other compounding features to make it a complex OSA like obesity. If it is significant, you must remove the tonsil and adenoids, must follow up these children after tonsil adenoid removal, because in all children, just by tonsil adenoid removal, your OSA may not disappear, especially if it's a complex OSA, like with obesity or with any other craniofacial syndrome or with Down syndrome. Okay, if you have a moderate to severe OSA, after removal of tonsil adenoids, you need to consider CPAP or other surgical options. But if after the removal of the tonsil adenoids, the OSA is mild, then you can still pursue medical management and follow up these children, right? If you do not find tonsil adenoids and these kids have significant OSA, then your options would be CPAP and other surgical procedures. So this is a 10-year-old boy. He came to me from Jalgaon, and his mother complained that she has never seen the child sleep comfortably. He was mouth breathing, he was snoring, he had a poor scholastic performance, and they also came with this X-ray. We normally do not do X-rays in all children because sometimes the position of the X-ray may mislead you. And also, this is something which is taking in a standing position. Normally, when you have obstructive sleep apnea, you have apnea when the child is lying down, you need to see it there. Okay, so here you definitely see the very large adenoids which are almost completely blocking the track. You can just see that. And you see this child's face. The parents were really handsome and beautiful. They had a nice round face. His face itself had become long because he had a long-standing OSA because of tonsil adenoidal hypertrophy. We did a polysomnography. If you see up here, this is N3 sleep. So he's fast asleep. So look what happens to him. He gets up. He's still asleep because when you look at the sleep recordings, it was sleep stage. It was not wake stage. Okay, he moves, right? And then look, I don't know why he keeps having these funny movements. He also squealed, shouted a little bit, and then he went back to sleep. So this is a confusional arousal. And this is a child who got this confusional arousal because he had severe obstructive sleep apnea. This was his sleep study. You can see here the flow events, first, second, third, fourth, the flow events. Okay, you see a lot of these light green bars, the parent green bars. Okay, they are all flow events, the obstructive sleep apnea. Along with this green, if you look at the red below, you can see it's dropping down. That's a drop in the oxygen saturation. This child had severe sleep apnea. Okay, and if you look at the first thing on top is the sleep profile. If you see, he is going into N2, N3 sleep. This orange are the stages of sleep, N1, N2, N3, and the blue is the REM1. Okay, so if you see, he got only one REM cycle, which is around 6 a.m., 7 a.m. in the morning. Otherwise, he kept oscillating, kept getting up. So his sleep was not even consolidated or restorative. So severe sleep apnea. Also, he had a confusional arousal. This is again a part of his sleep study. Here you can see the sleep profile very well. Only one REM cycle around 6:30 in the morning. And if his AHI, if you see here, was 30.3, suggestive of severe sleep apnea. This kid, he underwent a tonsil adenoid removal. We sent him for a dental reference. We also saw his teeth, and he had very less space inside his oral cavity. We decided to defer dental treatment, watched him after tonsil adenoid removal. We started myofacial therapy, which encourages children to go back to breathing from the nose. They forget to breathe from the nose. He was followed up after 3 months. He was excellent. He was much better. At 6 months, we repeated a sleep study. His AHI had fallen to less than 5, and he did not really need many more treatment. So many a times we have done a tonsil adenoid, and this is not the end of the story. This is something called as drug-induced sleep endoscopy. So if you can see here, below are the large adenoids, and this is a kid whom we had advised removal, disappeared for 6 months and came back. He says, I'm much better, but I'm still snoring. So we thought we should do a DICE before taking him through surgery. And if you see, his whole airway completely collapses. Okay, so the tonsil adenoid had reduced a little bit in size, but his whole airway was collapsing. We did his tonsil adenoid removal, but we told him that you need to follow up because it may happen that even post removal of tonsil adenoid, since your upper airway is the tone is not good, you may still continue to have sleep apnea. We are following up these children as of now. Look at this other video. Look at this child. What does he do? See what this child. He is actually, you may think that his eyes are open, but he's actually asleep. He has got off the bed. He has come down and sat. He gets up and he just moves. You see, he'll almost hit himself on the wall because he's asleep. He will just kind of, then he goes back. He moves right across the hall to the kitchen, almost falls, comes back. What is this? I'm sure most of you could guess what this is. This is sleepwalking. This is also a parasomnia. These are called non-REM parasomnias because they occur in the non-REM stage of sleep. And how do you manage this child? You have to just safeguard the child that the child does not injure himself. You should counsel the parents that most of the time that this is a benign condition, and most of the time these children will outgrow with age. So parasomnias are nothing but merger of the awake state and the sleep state. So they are undesirable, non-deliberate movements. And if they occur as non-REM parasomnias, child has no memory of this in the subsequent day, right? And so confusional arousals, sleepwalking, sleep talking are all non-REM parasomnias. Night terrors are non-REM parasomnias. REM parasomnias include nightmares, but nightmares typically occur in REM sleep, so it will occur much later part of the night, and children will have memory of that event. So this is very important to know because a non-REM parasomnia child is actually fully asleep, And whatever you may do to console the child, it will take time for the child to settle down and go to sleep. And you'll have no memory of the whole thing. So you just need to safeguard the child. In REM parasomnias, child is having memory of that, and generally the child is scared about something. You can talk to the child about it the next night, the subsequent nights before the child goes to bed. You can talk to the child about it, and you can make the child outgrow the REM parasomnias. Triggers could be fever, emotional stress, medications, and you can also have sleep deprivation, poor sleep hygiene. All of them trigger these parasomnias, and they also run in families. If you have obstructive sleep apnea or restless leg syndrome, again, these children can have, they can trigger of a parasomnia. So I've already mentioned about this. Okay, I'm going to skip this slide, and I'm going to show you another very fascinating video.
No, not there, Babu, not there. Go to the bathroom, man.
So this is a boy who's got up, he's shouting, crying. He's actually again asleep. This is a complex confusional arousal. It's again a parasomnia. The parents had to guide him, otherwise he would have peed somewhere because he's still asleep. He pees in the bathroom and is continuously crying. Whatever the parents will do to console him, he doesn't get consoled till the arousal disappears. So this has a confusional arousal, and also to some extent this child has a sleepwalking. So it's a complex non-REM parasomnia. Now look at this. Now here I want you to focus on the eyes of the child. Now this is a child who was brought to us who used to keep on crying, and it was passed off as a confusional arousal. Alright, and the child had no memory of the next day of event. Then we asked the parents to take a video because it was getting worse. So watch the eyes now. Did you see those blinking movements? Yes. So the child had a nocturnal seizure. So sometimes the confusional arousal and a nocturnal seizure may overlap. You may miss a nocturnal seizure thinking it's a confusional arousal. For that, you need to do a polysomnography with an expanded EEG montage to pick up these nocturnal epilepsies. So that's sometimes these videos, when you do a polysomnography, you always have a video camera, and you can pick up these kind of seizures, and also you can also record them on the EEG. Now look at this child. So this is a parent who was really worried about this child. This is a child when they put the child to the bed, the child used to continuously rock. So these are sleep related rhythmic movements. Many a times children do this to actually kind of soothe themselves and go back to sleep. All you have to do is you have to take care that the child doesn't hurt himself. With age and time, this disappears. In all of these parasomnias, you should ensure that there's no trigger. There's no obstructive sleep apnea which is triggering it. That's something which is waking up the child. The sleep hygiene is very important, and the child should see that the child is getting adequate amount of sleep that the child needs. Most of them disappear as the child gets older. Now look at this kid. This is a parent who brought this video to me. Look at the second video. And this was the kid I was following up for some time for asthma. Then mom said he's very hyperactive. And then he started increasing weight and he became obese. Now you watch, he almost stops breathing. He's getting a central apnea. Even his abdomen does not move. He just stops breathing. And then post that, he has something like a gasp to start breathing. So this was a child with Prader-Willi syndrome. Prader-Willi syndrome, the symptoms develop over a period of time, and sometimes you may miss them. So he had ADHD, he had short stature, he had obesity, and he had asthma. He had severe asthma. And then when the mom brought this video, we put all the things together. This was a child with Prader-Willi syndrome. In Prader-Willi syndrome, a sleep study is very important because they have a high risk of central apneas and even obstructive sleep apneas. And most of the children are now treated with recombinant growth hormone. If you give recombinant growth hormone, these are kids who will increase the size of their tonsil adenoids. Because they increase the size of their tonsil and adenoids, they can worsen their apneas and actually can cause acute sudden death. So in a child with Prader-Willi, where the plan is to give growth hormone, a sleep study should be done at diagnosis before the initiation of growth hormone. And then these kids should be followed up. If no action was taken and that time there was no sleep apnea, this kid should be followed up for the need of early tonsil adenoid removal or a BiPAP as per as per requirement. Now, I'm sure everybody recognizes all these children. They're all kids with Down syndrome. All of them, generally more than 50% of children with Down syndrome would have a sleep apnea. And by the time they grow, they become adults, they say almost 100% would have a sleep apnea. Multiple reasons. They have a small midfacial hypoplasia, large tongue, hypothyroidism, obesity, etc., hypotonia. So they tend to get sleep apnea. So the American Academy of Pediatrics recommends that a sleep study should be done in all children with Down syndrome by age 4. And of course, these kids should be followed up. If there's no sleep apnea, then they should still be followed up. Many a time we miss our kids with Down syndrome. This last child here, Rohit, I remember him very well. He had polycythemia. His hemoglobin was 23 and he had got all the workup done for polycythemia and nobody thought of obstructive sleep apnea. This is obesity. In COVID, we have seen so many kids with obesity that it was not funny. I've seen children, and the amount of kids with obesity, I'm sure all of us have seen, but because of a referral bias, I've seen so many children with sleep apnea requiring to be put on CPAP till they have a lifestyle change and they lose weight. Now, this was a kid who was referred again for a sleep study. So this kid had something called, by till 2 years, she was fine. And then she suddenly started gaining weight. So this was a rapid onset obesity with hypothalamic dysfunction, hypoventilation, autonomic dysregulation syndrome with neural crest tumors. It's called the Rohard-Net syndrome. These kids have central apnea, obstructive sleep apnea because of the massive obesity they have. This child had the works. She had diabetes, she had hypertension, she got COVID, her lungs got fired. And she was admitted multiple number of times in the ICU. But once we did a sleep study and we realized that she needs pressures to keep her airways open. Ever since she's on BiPAP, I'm only getting good videos with her showing that I'm well, doctor, I'm doing everything. Of course, she has a whole set of other problems and currently bariatric surgery is being planned for her. Now, this is a kid who came to me from Africa, 9th child of a big man in Africa, and this is a Treacher-Collins syndrome. So what I'm trying to say is many kids who have craniofacial abnormalities, I showed one achondroplasiac, they tend to have sleep apnea. If you look at his jaw and you look at his mandible, he has a retrognathia. So children with Pierre Robins, all these kids have a high risk of sleep apnea, and you must do a sleep study in them and pick up their sleep apnea and treat accordingly. So these are children with microtia, conductive hearing loss, they have slanting palpebral fissures, colobomas, midfacial hypoplasia, which makes them predisposed to sleep apneas. They may have a cleft palate, they may have corneal atresia or stenosis. This is another very fascinating case. Look what she's talking.
Why do you do this, Vinaya?
Because sometimes my fingers feel uncomfortable and I feel like my bones have to crack or something. That's why.
It doesn't pain, no?
No, it doesn't pain anything.
So this was the parent who was little worried. So she was wondering whether the child is actually having a problem or this is psychological. So this is something called as restless leg syndrome. Yes, restless leg is a misnomer because it can occur in hands. It's urge to move hands or legs. Usually it is accompanied by uncomfortable or unpleasant sensations. And the symptoms may occur as I told you, 30 to 50% of children in the arms. It is rest induced. It begins or worsens during periods of inactivity, gets better with activity, or the sensations then totally or partially get relieved by movement. Okay, and even eating may improve symptoms. These symptoms are worse in the evening and night. Okay, so remember this mnemonic called urge. It's a restless leg syndrome. It occurs because of deficiency of iron, because iron reduces dopamine in the brain and causes dopaminergic dysfunction, causing these disturbances. Is my time up?
Ma'am, sorry. Sorry to disturb.
Indu madam, we have to finish fast because sir is also waiting.
The last 2 slides and I'll be done.
Yeah.
Okay.
Thank you.
You can give iron to treat these children. I am going to skip this child just to give you a message. This is a child with a myopathy who was missed, who had 3 pneumonias, okay, in the past and was being treated with everything else. But this child had a myopathy. And if you see here, the CO2s are high. And these are kids who do wonderfully with when you do a sleep study and you start them on BiPAP. Post BiPAP, she has not had a single hospital admission. Children with kyphoscoliosis, especially those who start early in life, will have less lung volume and can also have a risk to sleep apnea. This is our little child. We just started him on BiPAP. He was a kid who underwent pneumonectomy because he had post-adenoviral, post-measles, one complete lung destroyed. So he had to undergo, and he's on home BiPAP doing well. So when should we do a sleep study? Respiratory, of course, when you have adenotonsillar hypertrophy, obstructive sleep apnea, obesity, craniofacial syndromes that I've shown you. Do not forget Downs. Neuromuscular disorders like DMD, spinal muscular atrophy, congenital myopathies. But sometimes you may have to do it for non-respiratory conditions like parasomnias, when you don't know whether it's nocturnal seizures or parasomnia, when you have periodic leg movement disorders, which is a polysomnographic diagnosis. Children who have these movement disorders along with OSA, you may want to do it. So I would like to conclude to say that sleep is essential and sleep history is equally essential. Please screen your children for sleep disorders. Snoring may be a lead point, but it may not really diagnose the severity or the presence of OSA. Sleep study is a gold standard for diagnosing OSA. Thank you so much. Any questions?
Madam, question and answer we will take at the end of the session so that
Sure,
we can take in
sure.
the continuation.
Thank you so much.
Anuradha madam, unmute. Pallavi, unmute Anuradha madam.
Yes, sir. Yes.
Thank you.
Pallavi
Thank
madam
you.
made
Thank you.
as
Yes.
well.
Thank you, Khosla ma'am. Dr.
Pallavi,
ma'am, it was a wonderful presentation.
Dr. Anuradha madam
We
को
will-
co-host बना दो.
किया.
Okay.
मुझे unmute किया है. I think we are running late, so we'll take questions at the end of the session. Now, I invite a very senior and experienced Dr. Ravi Ramakantan. He will be speaking today on ABC of pediatric chest radiology. I think this topic is close to every clinician and clinical pediatrician. So I think all of us are eagerly waiting for this lecture also. He's an honorary consultant radiologist in Kokilaben Dhirubhai Ambani Hospital and Research Center, Mumbai. He has done his UG and PG in radiology from GSMC and KEM, retired as a professor from KEM in 2020, and he has had 47 years of glorious service. He has earned the distinction in MD radiology it was given for the first time in 1980 to him. He is the founding president of Indian Society of Neuroradiology. Then he has won many awards like Best Medical Teacher, Karma Yogi, Lifetime Achievement Award. He has 70 research papers in index journals under his name. He is a visiting professor to Brigham's Women's Hospital, Harvard Medical School, and Radiological Society of North America. So we have such an eminent speaker today to enlighten us and to give us a better insight into pediatric chest radiology. So over to you, sir. Welcome, Dr. Ravi Ramakantan, and over to you for ABC of pediatric chest radiology. Thank you, sir.
Okay, thank you. You will not see my face. It's quite sleepy now. So I'll start with slide share right away. Okay. Why is it not becoming? Okay. This is mainly for Bachu Lok, postgraduate residents, very, very basic, literally ABC. And I start with this ABC. When you're making a presentation, whether you're doing it live in a conference hall, whether you're doing it on Zoom, have this one slide as a blank slide. It makes you, gives you an opportunity to set everything right. I hope you can see my slide. That's the usual question that people ask, but this blank slide takes care of that. Now, when you talk of pediatric chest radiology, there are several things that are important here. One and foremost, it is perhaps the most commonly asked radiological investigation in the pediatric age group, and therefore, it's important to know what it can do, what it can't do, and what it can do wrong. And there are several points here. Each of them will take 5 minutes, and I don't have no intention of going into the 9th morning, so I'll try to run through. That's not my characteristic of running through my slides, but let's see what happens. So rotations in pediatric radiology are a big deal. I probably will show you some examples of that. Now, when you look at chest film, the first thing that you should see is whether it is rotated or not. Whether the film is rotated or not is important. It is not time pass. It is not an exam question. It is real life situation where you can make major mistakes if you look at rotated films and make wrong diagnosis. So that's very important. And how to look for rotation and all that is a different ballgame altogether. Let's see if we can touch on some of them here. Now, supine versus upright. This is also a big deal, a very, very big deal, because life is so much easier if you can have an upright film every single time. And in pediatric practice, you know that it is not possible. Not just in infants, even in some children who are acutely ill, upright views are not possible. But when possible, as a pediatrician, you should insist that the patient be taken down to the department and upright film is obtained rather than taking the simple, easy way out, ask for a mobile X-ray by the bedside. Please do not do that. It's not fair to the patient. It may be fair to the ward boy, but not to the patient. So as far as possible, insist on an upright view. And I will give you examples or even a demonstration of how that makes a huge difference. The next thing is about inspiration and expiration. We do a big deal. In your MBBS days, you have been told that you should be able to count so many vertebrae, so many ribs, so many causal spaces, and then it's an inspiratory film. It's a good film. As far as pediatrics is concerned, that's a lot of hogwash. Forget about that. Because to get a good inspiratory film in any child less than 5 years of age is so very difficult. Because that poor child is crying. Perhaps the mother is not crying, but the child is crying away to glory. And then you get an expiratory film. There are smart X-ray technicians who allow the child to cry, and the child has to stop crying and then take a deep inspiration and then are able to expose during that time, and you get an artificial, highly inspiratory film that has diagnostic value. So the long and short of it is that in a normal child, in a sick child, a normal sick child, it is difficult to get good inspiratory films. And if you do persistently more than one image, see inspiratory film, something is wrong. I'll show you an example of that. When should we do a lateral view? Now, the important thing in Bachulog is that radiation is not safe. Radiation is never safe, but in children, it is less safe than in adults. And therefore, fortunately, we do not do CT scans at a drop of a hat. And those of you who are inclined to do CT scans at a drop of a hat should realize that keeping a child overnight starving, keeping a child starving till 8 a.m. and then till 10 a.m. and then selecting and then putting a tube down is no fun. So unless absolutely essential, and I'm very happy to see that the pediatricians I work with, do not ask for CT scans easily. They are extremely circumspect in ordering CT scans in Bachulog. So we can manage with X-rays for most part. Sometimes you can't, and of course you have to do CT scans. That brings us to the question of lateral view. Now, lateral view is a lost art. That sort of rhymes, isn't it? Lateral view, lost art. Unfortunate, because it has real value in some conditions, but because we don't do lateral views, we don't see enough lateral views, and you don't see enough lateral views, you don't have expertise in lateral view, therefore you don't do lateral views, and the fun goes on. But lateral views have real value, at least in one condition, and the most common one of them is pulmonary tuberculosis in our country. Then follow-up X-rays. It's interesting. Abdominal circumference, TDS. Blood pressure, TDS. Pulse, QDS. And then chest X-ray is QDS. No, you don't do that. There is very limited role of doing more than one chest X-ray per day. And that is usually in a situation when there is space occupation. Most of the time, it's say pneumothorax, or you put a tube down there, or whatever, or a post-operative patient. In an average pneumonia, there is no point whatsoever. Most of the time, there are exceptions. Of course, as a bedside doctor, you have to use your discretion. You can occasionally do more than one X-ray for a child with the consolidation, but usually once in 3 days or 4 days should be enough. The concept for young doctors there listening to me, hopefully, is that do not do unnecessary X-rays or CT scans in children, which brings us up to CT. I talked about that. Ultrasound is something that is very, very useful. Bedside ultrasound. Maybe you learned that bedside ultrasound, ultrasound is not useful when there is air, that's all gone. The ultrasoundologists in their conferences talk about how useful bedside ultrasound is for diagnosing all possible conditions in the lung, not just pleural effusion, not just consolidation, but pneumothorax, shifts, all sorts of things. And there are nice fancy names for these signs that you see on ultrasound. So if you have bedside ultrasound, and which I feel many of you who are doing critical work in pediatrics do that already, you should learn the fine art. I mean, it's not easy to learn that, but you can easily learn that. Am I contradicting myself? That's interesting. Yeah, whatever it is. Okay, so it's past my bedtime, so you should allow me. So you should learn the art of doing bedside ultrasound so that you can diagnose things easily, constantly on twice a day perhaps, and without radiation. So that is the new thing that bedside clinicians, I'm mainly talking about critical care people, should learn to use often. And I told you, radiation is never safe, not in children, not in adults. So avoid radiation as much as possible. Let's move on. Now, a lot of stuff has been talked about cardiothoracic ratio, and I'm showing this not to tell you how to measure cardiothoracic ratio but rather not to break your head about that. Don't take rulers, do not do measurements. I will go to the extent of saying even postgraduate students will tell their examiners it's a waste of time. If you can't tell whether it is 50% plus or 50% minus by eyeballing, that don't measure. It will always be maybe 50%, maybe 60%. So I have thrown away all rulers. I never use a cursor on the monitors because most of the time you can eyeball unless you are doing some follow-up studies and you're measuring or you're doing research. That's a different thing altogether. So do not easily measure, waste time on measuring cardiothoracic ratio because there is a particular way of measuring it. You can't measure it anywhere, anytime, anyhow. So I will not talk about cardiothoracic ratio. If somebody insists on that, look up Google. Google Bard is my favorite. It's time pass, full time pass. Ask Google Bard, please tell me how to measure cardiothoracic ratio, and you'll get a beautiful answer. Okay. So that the reason I'm showing this is please do not bother too much to measure cardiothoracic ratio. There's something else going on in this X-ray, and perhaps I'll come back to it a little later, but there is a very important finding here. And one of the things I want to stress here is something that will come up a little later in the course of this lecture. Okay. Okay, fantastic. That time has come. Now, those of you who are not having dinner and have both hands free, please take out your cell phone cameras. I want you to do this for me. And those of you who have listened to this lecture or any lecture from me in the past would have done this exercise, but it is perhaps worth doing it one more time. And those of you who have not done it, please do it for me. Take out your cell phones. Focus on anything in the room. Do not zoom out. Do not do anything. No zooming, nothing. Just point your camera to anything that catches your fancy in the room and take a picture. I'll give you 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, 0, time up. Okay, now I want you to look at that image that you captured just now. And you will see that on that image, you see a lot more, a whole lot more than what you saw when you were concentrating on taking that picture. Okay. I mean, I've done this enough number of times to know that at least for most of you who are doing it for the first time with me, this is what has happened. And this is the story of all clinical medicine. You've been taught from your first MBBS or second MBBS day that when the child has respiratory injury or anybody has a chest problem, put your finger on the subcostal region, look for the liver, look for the spleen, all sorts of things. Examine the patient as a whole, which is more true of radiology. So when you see that picture, when you're concentrating on something, you're seeing the patient. You sort of have a differential diagnosis based on your clinical exam. And when you look at the radiograph or CT scan or whatever, you're looking for that thing. You're looking at an image for something that you have thought would be on the chest film, which is fair. You are concentrating your attention on something, looking for something. Radiologists are trained just the opposite way. Look at everything. There's a big difference between looking for something and to look at everything. Looking for something does not automatically mean or preclude looking at everything. Now, I want you to look at this film, this chest film, and for yourself, note the main points that you see here. Okay, 1, 2, 3, 4, 5, 20, 37, God knows what, but at least you will see the position of the endotracheal tube, you'll see the position of the nasogastric tube, you'll see that there is a ductus clip, and then you know that there's something going on with the heart, the lungs are different, and all that this child has a congenital heart defect, has a ductus closed, and all this, okay? When you look at the position of the endotracheal tube, they are supposed to look at something else, and hopefully I'll cover that. Now, I don't know if I'll go into tomorrow morning, but please stop me when it is time up, okay? Now, we have now, let me see. Oh, what's the time? Okay, 2 past 10. I'll stop at 10:30 sharp, whatever happens, right? And I'm very likely I would have covered 5 or 6 slides. I don't care. Okay, I will say what all I want to say here. You also see that the bladder is a little full, and then you come down and you see what's happening to the femoral arterial catheter or the PICC line. How many of you saw it first time? And if you've seen it, I'll give you an honorary MD in radiology. That's a good thing. It's a good thing because that's what you should see. You should look for something and look at everything that is to be seen. It's a habit you create when you're a 25-year-old before you appear for your MD in pediatrics. The day you're born, in the postgraduate medicine, you learn to look at everything, not just for something. It's not play of words. It's a huge difference in the contextual meaning of those things. So if you're just looking at the lungs, you'll miss a whole lot of finding. And that happens off and on, especially in pediatric practice. You'll miss a little bit of liver, a little bit of spleen, which you may or may not have seen clinically. You'll see the endotracheal tube, but you'll not see what the endotracheal tube is doing in which position. So many, many things which are complicated about the endotracheal tube or the nasogastric tube. And I could do a lecture on just these 2 tubes. It's so badly managed. It's so badly understood. I'm using strong words. I'm not asking to be excused because those are the 2 tubes that I see misplaced day in and day out. And I report 100 ICU X-rays every day. Most of them, of course, are adults. Anyway, so, and you see a full bladder, so on and so forth, many other things. Now, as somebody who's treating the patient, many of these things will be inconsequential, like a full bladder. Maybe you'll put a tube there, maybe you'd say, okay, child will pass some warm water, hot bag there, something. It doesn't matter. But it is a habit that you have to learn, because what differentiates a merely competent amateur from a very expert professional is picking up those signs in those 2 or 3 patients which everybody else has missed. Not because you feel good, because it is right by the patient. It's not about us. Medicine is not about doctors. Medicine about patients. And I long since stopped saying, what an interesting case. All those interesting cases are unfortunate patients, and for you, unfortunate patients. So when somebody says interesting case or a fascinating case, I feel very sad. There are no interesting cases. Anyway, so this is the first part. This is the first lesson. I call it Ravi Ramakantan rule number 1. I'm not a very modest guy. I can be very pompous, and therefore I call RR rule 1. Look at everything that is there to be seen. Let's move on. Now, most of the time, there is no hurry to look at the film, right? I keep saying that the only person who is in a big hurry to look at images is those police walas at airport check-in counters. The bags are coming in, takadak, and these guys are looking at the monitor, and they have no time to look at images. As doctors, all of us have enough time, most of the time, to look at patients and to look at images. You don't have to finish off anything in 10 seconds, right? You can take 10 seconds, 20 seconds, 30 seconds, 1 minute, whatever. And it has been shown repeatedly in radiology literature from the 90s, 70s down to now, that the longer time you spend on the film, the more finding that you'll pick up till you stop looking at chest film. These are done on chest film for 1 minute. Till about 1 minute or so, you'll start continue to pick up findings. Now, do I do that? No, I don't do that. I'm just a teacher. I tell people what to do. I do what I damn please. That's because I was not trained to do this all the time. People told me, don't hurry. But there was nobody standing with a danda and telling me, don't hurry, look carefully. Now, if you look carefully here, you do all sorts of things with the heart and the lungs and the thymus and the liver and the spleen, and then you see something in the rib on the left side. You can count anyway, 1, 2, 3, 4, 5, 6, 7, 8 rib on the left. There's something going on there. And then you compare the soft tissues on the right side and the soft tissue on the left. You see there's a little bit of swelling. And my teacher in second MBBS in 1973 told me, boy, God has given 2 sides to compare. And it's very useful in pediatrics especially. So you don't require to compare the left and right to say that the left rib there is abnormal. Do you want me to point that out? Where is my pointer? There you go. This left rib is abnormal. There's soft tissue swelling. This is a child, whatever, I don't remember now, I think 8 or 9 or 10 months old. This was metastasis from a Ewing sarcoma that was in the calcaneum. This child came with that lesion, was being treated for that, and then this was found on a chest film. Not expected. And then you go back and examine the child. Definitely there is a swelling there. I mean, you don't blame a pediatrician every single time to look at the chest wall from behind and say if there is swelling or not. But when it is seen on a chest film, you should pick it up. And of course, you go back. If you see it on the chest film, you'll always see on clinical exam that there is a swelling there. So not looking for something, but looking at something will help you pick up lesion, obviously, that you do not expect to see. And I told you, it may happen once or twice in 100, but that's about that 1 or 2 patients. Okay, one more time, we'll go on. Now, again, when you have a big mess of stuff like this, the post-operative patient at Coxsackie, we see a whole lot of pediatric chest X-rays, which are immediate, a little later post-op, and there is a lot of garbage on this chest film, and then you have to quickly filter them out and pick up what is abnormal. So the first lesson, therefore, was to look at everything that is there to be seen. The second lesson is to look in some particular areas for lesions. And one of those areas is behind the heart. I'm not going to tell you about silhouette sign now, and not at 10:30 at night, but you can see here that there is this linear shadow, which is seen through the cardiac shadow. So when you see something like this, now or 100 years later, it's almost always collapse of the left lower lobe. Now, if you do not have properly done chest films, if you do not have the ability to look at X-rays on monitors, you may miss this. I mean, you may find it on clinical exam, something going on, some foreign sound posteriorly, but you look for it, you'll find that there is something behind the heart on the left side. And I'm sure most of you picked up what's going on the right side. There is consolidation with air bronchograms on the right side. That is the easy one to pick up. This perhaps is a little more difficult. And the most difficult of all in this, the patient's real problem is peripheral airway obstruction. Black shadows are generally more difficult to pick up than white shadows. So if you're looking at a CT scan of the brain, you'll easily pick up hemorrhage. And that's how the human eye functions. The human visual system functions, and that's been shown again experimentally. So you have a tiny infarct, you're likely to miss on a CT scan of the brain, but if there is a small drop of blood, you'll pick it up easily. So these shadows, one in the right paracardiac region, which has undergraduate air bronchograms, is the easy one to pick up. The retrocardiac shadow on the left, which has this classical sail-like shadow, if you want to call it that, a linear shadow, sharply defined at varying distances from the spine, depending upon the amount of collapse, is always, every single time, in a pattern like that, is left lower lobe collapse. Now, radiologists talk like weather fellows, right? Possibility of rain, this and that. And you would have noticed that I say almost always, most of the time, right? But this time I'm saying without exception, because this is so classical that when you see something like this, with or without clinical signs, I don't care. This is left lower lobe collapse. And most important of all, keep looking, and see why is it that the rest of the lung is so black. Now, it could be because of exposure factors, but compare the right dome of the diaphragm, which is near normal, with the left dome of the diaphragm. The left dome of the diaphragm is flat. It has lost its normal convex or concave contour, so there is air trapping here. This time, this side is partial air trapping. It's not fully flat like this. Now, when you have flat domes of diaphragm, that severely compromises breathing gas exchange, right? I mean, there's a lot of physics involved in that when there is flattening of the domes of the diaphragm and there is inversion of the dome of the diaphragm, so on and so forth. So this becomes significant. As pediatricians, you see a lot of air trapping along with or without consolidation, say bronchiolitis, for example. Classical example where you see black lungs rather than white lungs. So this is an example of multiple findings on how you will filter through a lot of garbage here and come to what is important. You'll also see here that there is a jugular line here. People call this different things. I'm used to calling it a jugular line, and you have to note the position of that. Every single time, look at every single time thing, and also look at this, right? This is rickets. A large proportion of children who have congenital heart disease are poorly nourished. I mean, you get into the demographics of congenital heart disease in a hospital, it's so very distressing. Okay, it's preventable in some ways, but what these children and parents undergo before and after cardiac surgery is something that makes you really, really sad. Anyway, so these children often have rickets and sometimes scurvy, and that is there to be seen on the chest film and you have to look for it. You see that you treat it, right? The cardiac surgeons are often interested in what is going on in the heart. If this child comes to the ICU, cardiac ICU, and there is a pediatrician looking after that, she or he may pick that up. Otherwise, this child will have everything done, no vitamin C, no healing, no vitamin D, no healing. What is he doing without treating the basic healing functions? Okay, now here we have a situation of real life, and this is important. I talked to you some time back about rotation. In your MBBS days, long ago, perhaps you learned that you measure the distance between the medial ends of the clavicle and the midline, and then you know whether it is perfectly centered or not centered. Try to remember who told you that. That must have been a tutor or a lecturer or a registrar in the medical unit, right? Adult medical unit. It may be true in adults, but it is not true in children. Surely not true in children below 5 years of age, because if you have seen how children's x-rays are done, the child is on the x-ray table, the child is trying away to glory, there's somebody trying to hold the child by the shoulders, somebody trying to hold the child by the hips, and the child is doing Bharatanatyam between the shoulder and the hips. The child twists and turns. Therefore, this is important. Wake up. Stop eating. It's not enough to measure the distance between the medial end of the clavicle and the midline. Now, this fellow on this side has closer, and this fellow, medial end of the clavicle, this side is farther away. Okay? So this is rotated here. I mean, there is no question that it is rotated. But if you measure the anterior ends of the ribs, that's the other thing that you should be doing every single time. When I say every single time, I mean every single time. And when I say measure, I mean you can eyeball them. This distance between the anterior end of the rib and the midline versus the corresponding rib on this side. This is closer, this is way away from here, and therefore this again is grossly rotated. Now I'm not going into which oblique it is, what becomes black, what becomes white. I mean, that's one full lecture, even for radiologists, residents to understand the physics of it, but it's important to look at the clavicles and also at the ribs. Because it is rotated this way, because this clavicle is closer to the chest, I mean to the midline, the heart will shift to the opposite side. So you stop thinking of this as pneumothorax or whatever, and that there is so much mediastinal shift. So much of pediatric radiology can be changed if you are aware how to compensate for abnormally done chest wound. So they're not going to go away. Every child is crying. You can try your best, but you cannot keep on exposing till you get a perfectly unrotated foot. So learn to look at rotation, and then the bigger picture of how to compensate for that has to be on a Monday morning, okay, or a Sunday morning, not at 10 p.m. at night. Okay, let's move on. Now, this is interesting, okay? So you look at the clavicles here, they are not too bad. The heart is shifted to this side, and there is blackness here, okay, whole lot of blackness. That's not enough. This dome of the diaphragm is flat, this is not flat. So you have mediastinal shift to one side, the opposite side, let's call it opposite side, the ipsilateral lung is black. So this is obstruction. It's simple. Though that dome of the diaphragm is flat. So this is obstructive emphysema of whatever etiology. The whole of that lung is abnormal. The opposite lung usually gets recirculation of blood. Therefore, it is whiter. That's fine. And you then think of what possible causes are, and that it is most of it is clinical. You have a history of possible injection of Shengdana, and then the child is coughing away, and then mother doesn't sleep, the child doesn't sleep, there is no fever. And to think of a foreign body, and you see something like that is classical. You may or may not do a CT scan, and everybody does CT scans now for foreign body. So it's important thing to pick up is that there is mediastinal shift here, and there is hyperinflation here, and this is what was removed at bronchoscopy. A peanut. Homework for all bachulo. And this is serious homework, right? I've been doing this homework for 30 years now, and I have not got a satisfactory answer. Why is the peanut the most common foreign body in the pediatric age group? There is a why. And I keep telling my radiology residents, keep asking why. Why is the green stick fracture called a green stick fracture? Why is the peanut the most common foreign body in the bronchus in children? Why is it that foreign bodies in children maximally occur between 2 years of age and 5 years of age, and like magic are rarely seen before 2 years and after 5 years? Forget all that question. Why is the peanut? And it's not only in our country, it's all over the world. Some people call it peanut, some call it groundnut. It doesn't matter what you call, whether it's American or Indian. This damn thing is the most common foreign body in the bronchus in children and can produce a lot of harm if not diagnosed properly. So my question is, if you can even guess an answer, you can read whatever you want. This is an open book question. You can talk to anybody you want. You can discuss among yourself. You can ask Bard. You can do Google. You can do what you want. But if you find an answer, you can write to me at raviramakantan@gmail.com, and I will let you know if that is a reasonable answer or not, because I have an answer which obviously I feel is near perfect. Okay, I'm not giving you that answer now because it's still near perfect. Let's move on. Okay, I will stop with these slides, and I think I cannot go more than this. It's a little tricky for me because I'm normally fast asleep by 9:15 p.m. Okay, I wake up at 3 or 4 in the morning. So if you want to come for a lecture at 3 in the morning, I'm glad, but I'll have to stop now. Is that okay, or do you want me to carry on? Somebody tell me something.
Sir, if you can
Whatever.
continue for another 5 minutes or so,
Yeah,
if
I'll
you have the
continue.
time.
Yeah, I have the time. The only thing that my voice will stop, I'll be sleeping on the monitor. Carry on.
No, sir.
Yeah, okay, fine.
5 minutes. Sir.
Yeah.
Thank you.
So this is something that you have to know. I mean, this is again fundamental. And this fundamental principle governs, because you guys are the ones who ask for X-rays, right? So somebody comes to the bedside and takes an X-ray that you asked for. And if you do not understand the simple physics of what's going on, you will not ask for the proper X-ray. And I talked to you about upright views and so on and so forth. Now, this is a bottle which contains green stuff. And this is something I did as a so-called experiment at home. Now, when you're sitting at home, when you have no work and you do these experiments, and I want all Bachulog also to think of doing in vitro studies to prove what they think is right or wrong. For example, why is a peanut the most common foreign body? So if you have a wind tunnel at home, the next question is, how do you create a wind tunnel at home? Anyway, so this is a bottle which has a green stuff. When you take a supine AP view, the damn thing settles down to the bottom and you do not know what's going on. Okay? Imagine this is the top of the bottle, this is the bottom of the bottle, this is the inside of the bottle, and I made the bottle on the floor or whatever, I don't know where, and I took a picture of this. All this green stuff is in the bottle. And then I did a lateral view of this. Same thing. It shows more of the green stuff. And you do not know what is going on. But if you really want to know what is going on here, this is what you need to do. You need to do an upright view. So you have a pleural effusion with kachra. Here, for example, you can't even tell there is pleural effusion because this is supine. But had you done a upright view, and if there was air in the pleural cavity, you would have got the fluid level, excuse me, and then you would see the green stuff on the surface. This is the difference an upright view makes to what you look at in the pleural cavity. Okay, you cannot do an upright view. The patient is too sick to be made upright. Okay, now upright is often called as erect. There is a subtle difference between erect and upright, so I use the word upright. And then you can do this. This is the same thing with a fluid level. I took the vertical bottle, made it horizontal, and took a picture from the side, not from the top. So when you take a picture from the top here, you get an AP view. when you turn the patient around and take a picture like that, you get a lateral view. But the patient is lying supine on the bed, and you take an X-ray from left to right. That is called a decubitus view. That's called a lateral decubitus view. There's a whole lot of difference between the lateral view and the lateral decubitus view. So if you're looking for anything in the pleural cavity, air or fluid, and you cannot do an upright view, then do a lateral decubitus view. The same thing applies for pneumoperitoneum. So whenever you can't do an upright view, you can do a lateral decubitus view. You're looking for pneumoperitoneum, then you do a left lateral decubitus view. The left lateral decubitus view means that the right side is up, so that air collects between the liver and the abdominal wall. So you do a fluid, if you want to see fluid level, ask for a decubitus view. Let's move on. And then this is the real McCoy. Now that's homework for you. What is the real McCoy? It's a very, very American term, but if you feel like you can Google and find out what is real McCoy. Now, when a child is supine on the bed, the most dependent part is this part, the head end of the bed, of the chest. So if you do a shoot-through view, you will find that there is more pleural fluid at the top. The moral of the story is this, that if you are taking a supine view, straightforward, run of the mill, everyday supine view, look for pleural fluid. You do not look for pleural fluid here. You look for pleural fluid at the apex of the lung, where the apex of the lung is blurred out by a pleural cap. So you're looking for pleural fluid there. So too, if you're trying to drain small amounts of pleural fluid, that tube, pigtail drain catheter, should perhaps be right up there at the apex of the curve. These are small experiments, they're simple experiments. They don't take time, they are fun. That make you think, they make you smarter. I mean, don't look at me, I'm not smarter, but I'm telling you, at your age, it's great fun to try out things, and you'll keep trying out all your life. Okay, let's move on. Now, this is the other part of the story, okay, where you will have to be aware of variant. Now, people say normal variant, right? I don't like that word normal variant, because when you say variant, it's usually normal. So this is the classical sales sign of a normal thymus. This is a thymus gland. It keeps on doing what it damn pleases from day to day. I mean, it's quite simply amazing to see what it does. Now, we have these pediatric cardiac cases where we have X-rays done maybe twice a day, maybe definitely once a day, and we see what's happening to the thymus, even pre-operatively. Post-operatively, they knock off the thymus, but pre-operatively, you see that the thymus keeps changing. So this is classical superior mediastinal mass, okay? And this is one time I'm going to say 100%. This is thymus, because it has this sign called the thymic sales sign, okay? Homework. Why does this thymic sales sign form? It's limited below by the minor fissure. But why is this so specific for thymus, and why is it not seen in other paratracheal or anterior mediastinal masses? Keep thinking, okay? You can, if you want, write to me, RAVI, RAMAKANTAN@gmail.com. I don't use WhatsApp at all. So that's was the problem why this lecture started early. Somebody was sending me WhatsApp images. I said, what WhatsApp? I don't know what's WhatsApp. So, I mean, I must apologize. I mean, that it was bad on my part not to tell the organizers that please send by email. I'm an old man. I work on email. Anyway, so you have to email me the reason why this is so specific for thymus. The other thing that happens with thymus, and you can easily tell that this is thymus, is the other sign. The first one was called the thymic sales sign, because when you know these signs for sure, you make a diagnosis for sure, you don't do unnecessary tests. You don't do a CT scan. Arey udhar kuch bhi hai. Okay. So this is on the left side is called the thymic wave sign. Okay. This thymic wave sound is produced when the anterior costal cartilages impinge on the thymus and they sort of indent that. And this is a thymic wave sign. Okay, diagnostic, again diagnostic, 100% sign of a normal thymus. Why is it that this appearance is not seen with other anterior mediastinal masses? And I will challenge you to see properly now. And if you're using cell phones, just forget it. Okay. As radiologists, I quite simply hate people making diagnosis on cell phones. And they will say, and I have to say this, because you are pediatricians, you're not orthopedic surgeons. Orthopedic surgeons can see fold on cell phones, not pediatricians pick up subtle hyperinflation on cell phones. I'll tell you that please avoid making any diagnosis on cell phones. If you are careful, you want to be 100% right about your patients. And WhatsApp is so easy. Any idiot can take a picture and send it to you by WhatsApp, and then you had nice blue pictures. When was the last time you saw a nice black and white picture on your cell phone? And it's so much easier. If you get that cell phone image sent to you on email and you see it on a large monitor, I mean, I can go on and on. I mean, I have battlefields on this about not seeing images on cell phones. Anyway, you know, a cell phone costs 20,000 bucks and an average radiology monitor costs 3 lakh rupees. There must be a reason why this is done. That radiologists make mistakes all the time is beside the point. It has nothing to do with cell phones or with monitors, but it's important that if you can sit on a film and not on cell phones, definitely not cell phone unless you're on the moon and there are no other way of looking at these images. So this is the thymic wave sign. You see, the trouble with me is this. You give me more time and I'll give you more philosophy at 10 o'clock at night. Okay. This is something that will happen, and I think I can bypass this. We talked about this a little bit. Okay, this is another thing that's important. When you look at this, and I started off the lecture with this, and I told you that it's not common to be able to get nice inspiratory films in the pediatric age group. Nice black lungs, diaphragms are low and down, and you'll call it normal. Don't call it normal because a nice inspiratory film 9 out of 10 times is abnormal, and most of the time it is bronchiolitis. You look at the child has fever and is coughing away to glory, and you call it normal. And if you see two of them like this, okay, just one is enough. But if you see two of them like this, nice, deeply inspiratory film, it's almost always, that's radiologist for you, almost always abnormal and indicates peripheral airway obstruction. It may be bronchial asthma, it may be viral bronchiolitis, it may be any damn thing, but it is not normal. Okay, I promise you this will be the last slide now. Okay, this is fantastic. I'll end with this. This happened earlier, and I told you that I'll touch upon this a little later, and this is where it comes. Look at this and see what you find. Now, the normal trachea, when you examine clinically in the suprasternal notch, is expected to be in the midline. We were taught that in second MBBS, and it's probably true even today. But we look at the trachea at the carina, at the bifurcation, simply because we can see that. Pay attention. The normal trachea, as it travels downward to the carina, the normal trachea moves to the right. I could ask you why. If this was a live class, I would ask you why. It's because of a normal left-sided aortic arch. In children who are more than 5 years of age, the aortic arch starts unfolding and the normal trachea shifts to the right at the carina, not in the suprasternal notch. Therefore, in older children, 5 years plus, if you see the trachea to be either in the midline, and I'm assuming it's a normally not significantly rotated form. If you see the trachea to be in the midline, not going to the right, or as in this case, the trachea going to the left, it's always, every single time, abnormal. And one of the causes for that is a right aortic arch. Given that the normal left aortic arch shifts the trachea to the right normally, if the trachea is shifted to the left, it's often by the right aortic arch. You can see the whole right aortic arch coming down. What does it mean? It's a different ballgame altogether. You write a normal right aortic arch, the patient reads and comes and asks, what is to be done? That's a full lecture. What is to be done with a right aortic arch? So this is a right aortic arch. I want to stop here and I want to tell you an anecdote which happened very recently. Now, when you work with children, with students, you have all sorts of experiences, and this one takes the cake for it. So I was talking to a bunch of radiology residents, 20, 25 something. I showed an X-ray somewhat like this. That was an adult X-ray, and this boy is supposed to describe it and make a diagnosis. And he looked at it and said, "Sir, right aortic arch." I was taken aback. My God, this guy is a smart guy. And then I said, "Why do you say it's a right aortic arch?" And then came the million dollar answer. Why do you say it's a right aortic arch? And there came the answer. Sir, because it's not a left aortic arch. With that, we will stop and we'll see what is to be done later on. Okay. Any final remarks, anyone? It's a right aortic arch because it's not a left aortic arch. Can you believe that answer? And if you were an examiner, what would you do to this guy? Okay. So I want to stop here. And I'm sorry, I cannot continue. I mean, I'm 70 years old. I've got all sorts
yes,
of
sir. Yes, sir. Yes, sir.
issues.
No problem.
Yeah. That's it? Okay, I can go?
Thank you,
Yes,
thank
sir.
you, sir. Sorry,
Anuradha
sir.
madam, any question for the sir, or we can take the question for Indu madam?
No, there are no questions.
There can be no
Okay,
question
the-
because I don't know the answer to the question at the best time of day, not at 10 o'clock. Okay.
Yeah. Okay. Thank you, sir.
Okay, chalo, bye.
Sir, sorry for troubling you
No,
so late.
please.
Yes,
I mean, don't
sorry
even
for the
think about it.
delay.
Don't even think about it. It's fine. I understand when you organize something like this. So that is the
But
least
it
of
wa-
your problem. It's fine. For the first time in my life in 5
But-
years, I'm awake at this time.
Thank,
Okay,
thank you,
chalo.
thank you for that because it was a wonderful
Okay,
lecture.
fine.
Thank
Chalo,
you so
bye.
much. Good night.
Bye. Good night.
Anuradha madam, any questions
Yes.
for Indu madam? I hope
No.
Indu madam, you are awake.
Yes, I'm awake.
There are no questions in the chat.
So in the chat box, there were 3 questions which I saw. There's one question which said that why do children get up crying? Okay. So I guess if you see, it is only the younger children who get up crying and not the older kids. Older kids will get up as they have to get up. The reason why there is no scientific reason here, but whenever you have it's the wake state, like I guess nature makes them cry because this is something like a signal to the parents to say, come on, I'm awake now. If they wouldn't make that noise, there would be some children who get up and who keep playing. It would happen. So I don't think there is something abnormal about them crying. There was one more question on night terrors. So night terrors, how do you manage night terrors was the question. Uh, when you have children who have night terrors versus nightmares, you have to first differentiate between the two. Night terrors occur in non-REM sleep, and night terrors where children will get up shouting, screaming as though they have seen a ghost or something like that. But these children are actually not awake. And then you have to just see that they are safe and they're not falling off the bed or something like that, and just let them be and they will go off to sleep. Night terrors invariably go away with time. But when you have a nightmare, it is more in REM sleep. It occurs in the latter part of the sleep. The child may have seen a horror movie or may have been scared by something. So you have to talk to the child in the day to say that, okay, these things don't exist or this can be sorted out like this. So you have to give the power of suggestion and power of good thoughts to the child. Do it every evening for a period of a week, 10 days. So generally when the child will go off to sleep, give a happy ending to the story that he has seen as a nightmare, and then the child will outgrow it. Sleep hygiene is very important. So you should see that the child is adequately slept. Because if the child does not sleep adequately, then these things always are more. That's the only way that you would treat a nightmare. And they always outgrow it with age. These are the 2 questions I saw in the chat.
Yeah. Thank you, madam.
Thank you so much for
Anuradha madam.
inviting.
Yes.
Any-
Okay. I think
You can
it's been a long
conclude. You can
session.
conclude. Yeah.
Yes, yes. Both sessions were very, very different and very, very interesting. And coming from experts as they are, they really gave a lot of clarity. I will definitely look at, I think most of us will look at X-rays with different eyes from tomorrow, and also take sleep complaints more seriously. I think these are the two takeaway messages. So I think it's time to say good night. And before I say good night, I want to make one suggestion. A request to everyone that whoever has, wherever the voting has not happened yet on the 13th and 20th, it's an appeal that we as responsible citizens must go and exercise our right to vote. I think that is a very, very important message I would like to share here. And good night from all of us here.
Good night.
Over to you,
Fri-
Jayara sir,
fri-
for the last
Friends,
comments.
we will meet on 10th with the protocol in pediatrics. So that would be the next